Hello, everyone. Thank you very much for joining us. I think it's good afternoon for some of you, it's good morning for others, and it's probably good evening and late evening for others. So we're very excited. This is a webinar being brought to you from NYU Langone, the orthopedic webinar series. And this is unique for our orthopedic webinar series in that we have participants who are international around the world and also registrants, people watching this from around the world. So this is really unique. We're really excited to start this webinar series. This is brought to you from the Center for Amputation Reconstruction here at NYU Langone. Just very briefly, this center is a multidisciplinary center at NYU that treats patients with limb loss, both upper extremity and lower extremity limb loss, which is really an all-encompassing center that focuses on all the issues that patients and individuals that have limb loss have, to really treat them in a way to regain not only their function, but be able to thrive in life. So my name is Jacques Hochboard. I'm on the bottom left. I'm the co-director of the center, and my colleague, Omri Aylon, is in the middle. He's also the co-director of the center. We've been doing this now for, I think, about 5 years now, I believe. And then Diane Atkins, who is pictured here on the right, she is our director of education for the Center of Amputation Reconstruction, and she's a world-renowned occupational therapist that deals with patients with limb loss. So to get started, a few years ago, we saw that there was a real need for education when it comes to upper extremity reconstruction. And with the help of probably some of you on the call, some of you that are participating, as well as our fellow speakers, we organized the first annual Bionic Reconstruction Conference here in New York. And this followed after the period of COVID where the education programs had laid dormant for a while. But that was a great success. And what it showed us is that there is a real desire and a real hunger for coming together and speaking about bionic reconstruction at a very high level. And people were very enthusiastic, and the conference was much bigger than we had initially planned. On the heels of that, we're continuing this, and the next Bionic Reconstruction Conference is next year in Charlotte, North Carolina, which we're organizing with our colleagues at Ortho Carolina's Glenn Gaston and Brian Loeffler. So if you have availability, we encourage you to attend. And the purpose of these webinars is one, education to bring us all up to the speed of what is the cutting edge of upper extremity reconstruction, but also as a precursor of what we will be discussing and how we will be discussing things at the next Bionic Reconstruction Conference. So this is the first of our series of webinars leading up to the BRECON conference in Charlotte next year. And this one, we focused on sensation. Now, we as clinicians, we can easily see motor function, we can see movement, we can see absence, and we can see presence of the limb and of the fingers. We can measure strength. We can measure range of motion, but one of the things that we really struggle with is sensation. We can't see sensation, but as we know, the literature is replete with strong evidence of how the lack of sensation is one of the biggest factors in patients having usefulness of their limb. And with prosthetics, for a long time, we've focused so much on motor, on the ability to move, on the ability to have strength, but we have not focused much on sensation for a few reasons. But one, it's also incredibly difficult of how to enable these patients to regain function with sensation. So this webinar focuses on sensation. It begins the conversation at a very high level. We have 3 world-renowned speakers that are participating today, and we're very happy to have them. Alex Cardetto from Italy is a friend and a surgeon who's made great advancements and been very innovative in the work that he's done. We're very excited to have him share that with us. Silvestro Mitzera is a scientist from Italy and also from Lausanne, Switzerland, who I have not had the fortune of meeting in person, but I've seen his work and I've read his work, and he really is a true pioneer, and we're very enthusiastic to have Silvestro Mitzera with us. And then Dustin Tyler is someone that we've known for a few years now, and we've had him as a speaker at the Bionic Reconstruction Conference and also a few events since that time. And his work is always just it just blows me away in the things that he's done and the things that he continues to do at Case Western in Cleveland, Ohio. So without further ado, I'd like to introduce our first speaker. The order, it will be Dr. Gardetto, then Dr. Machera, and then Dr. Tyler. At the end, we will have a question and answer session. Please feel free to type in your questions. We will not be answering the questions during the webinar, but at the end of the last speaker, which is Dr. Tyler, we will have a question and answer session. So please send in your questions, and then my colleague and co-director at the Center for Amputation Reconstruction, Dr. Ayalon, will be leading that question and answer session. So the first speaker is Dr. Gardetto, and thank you so much for joining us.
So first of all, I would like to especially thank you, Jack and Omri, as well as Diana, for organizing this wonderful webinar, and also express my gratitude to New York University for making it possible for us to hold this event today and here in Italy tonight. And furthermore, I would like to extend a warm welcome to all the attendees who have joined us online. It's not working.
While we wait for Dr. Gardetto's talk, it's working?
Yes, now it's working. Now it's
Great.
working.
Okay.
So I would like to talk about the TSR, the targeted sensory renovation. And Immanuel Kant had a nice sentence, the hand, the tool of the mind. And that's true. The hand is a versatile tool that allows us to interact with our environment through the touch. And it perceives texture, temperature, shapes, enable grasping, manipulating and exploring the objects. And the hand also aids in searching and navigating spaces by providing sensory feedback, making it essential for the perception and action. So you have to know that the hand weighs less than 1% of the total body weight. However, it occupies 30% of the sensory motor cortex. And the question that arises for us was how we can close the lack in the sensory cortex after loss of the hand, of the transradial amputation. And you know, the phantom limb pain or also the sensations affect a high percent of the amputees and massively impair the quality of life. And the treatment of these patients remain challenging. You know that all, and this in most cases limited to the symptomatic treatment. And now one of these tools is also the TSR. Based on our experience with the TSR surgery on the lower extremity, we have then extended this technique to the forearm for patients with the hand amputations. And the indications for us for the TSR, especially the inclusion criteria, treatment-resistant phantom and or neuroma pain, or the acute or the elective programmed amputation for prevention of these pains, and nowadays also the partial brachial plexus injury with preserved flexion, and the action function of the elbow and the sensitivity in the volar forearm, and of course a complete non-functional hand. And the aim is to create a genuine, authentic sensation with the TSR to the sensory feedback on the renovated area of the forearm. The surgical technique involves the neurography of the median and the ulnar nerve with the lateral and the medial antebrachial cutaneous nerve respectively in order to renovate the skin of the residual stump. You can see here these two pictures, the recipient nerves. And at the end, the patient, after the renovation, we can see a so-called phantom limb map or a phantom hand, and the patient is able to perceive all the fingers of this of his hand. Here you see an animation. These are the recipient nerves. Then we have to perform the amputation about 7 centimeters proximal to the wrist. We have to dissect here the median nerve into the radial and ulnar fascicle and the ulnar nerve in the superficial and in the deep branch. The deep is the motor branch. Then we have to dissect the recipient nerves under or below the elbow and do the TSR1. I have then to explain a little bit the TSR2 and the TSR3 so that all nerves of the hand are there, and at the end also the TMR. You can see here then, you can see the fitting of the prosthesis, and the prosthesis have sensors at the fingers, and when the patient grips something, this sensation is transferred to the actuators, which are vibrators, which are positioned over the phantom limb map or over the renovated hand, and they vibrate then. And this sensation is then transferred to the brain, thus the brain is tricked in thinking that the hand is still there, and the conclusion or the result is that the phantom limb pain disappear or not occur at all. And you see here the first indications. It was the first TSR in this patient in 2020 in a trauma hospital in Klagenfurt after painful non-functional left hand after severe contusion trauma. He was operated a lot of time, and then there was the decision to have the elective amputation. These are examples for two secondary cases with heavy phantom limb pains. This was one also a heavy case with irreversible congenital vascular disorders after vascular attempt to revasculation, but there was no chance. And this was a post-traumatic or the traumatic case. This was also a heavy case in the University Hospital of Padua. You know these cases, Waterhouse, Friderichsen syndrome with necrosis of all four extremities. And these are two peoples, the first with the partial plexus palsy. And I would like also to show you one case. It was plexus palsy, partial, after a birth trauma 55 years ago. So first you have to begin to transect the median nerve. It's very easy with the forceps. You can divide these fascicles in the radial and the ulnar fascicle. And I showed you before in the video, you have to do the TSR1, what means that is the renovation of the first, the second, and the radial half of the third finger. With the TSR2, you have to renovate the ulnar half of the third finger and the radial half of the fourth finger. So this is the median nerve. This is the renovation of the whole median nerve. And with the TSR3, you have to renovate the ulnar half of the fourth finger and the fifth finger. And so you can receive this phantom limb map. Post-operative, we treat the patients with TENS therapy about 2 weeks after complete healing of the wound. Maybe we began with 2 times a day with 15 minutes, but the patient can do it how often he wants. And you see here, the video is not so good, as I know. But you know here, this patient, 4 months after the surgery, he was able, or with the progressive renovation of the forearm skin, he was able then to gradually record or to paint the so-called phantom hand with the spatial resolution of each individual fingers. And when they touch the skin, each individual finger could be perceived precisely and genuinely. And some questions in the conferences, in the meeting, where can they feel how can they feel the space between the fingers? And I said, then I have to speak with the patients. The space between the fingers can't be divided. The patients draw the hand as they feel and imagine it. And also other questions were if there is a hypersensitivity, because we know that as plastic surgeon, when you have to do a reconstruction of these nerves, there is almost a hypersensitivity. In these patients, we have no hypersensitivity. The patients where this is also knowing Professor Mechera, they can differentiate in between cold and warm, and the expert is here, Silvestro. So we also detected the somatosensory evoked potentials in the EEG, and we saw there not only in the healthy part the SEPs, but also in the impaired part. And together with the sensory nerve action potentials in the nerve conduction studies, these are clear sign of central renovation. So we had no phantom limb pain occurred in the elective amputated patient or in the acute trauma patient. And in all patients which underwent the secondary surgery, the preoperative pain improved significantly to completely or did not occur at all. And that's very important. No significant pain medication was necessary in the long term. And the sensory renovation was obtained about 2 months after the surgery and complete then after about 6 months. And the PLM of all 5 fingers at the level of the residual limb could be generated in all the patients that we operated. There was no hypersensitivity, a differentiation between hot and cold. And that's for me very important. There is no need to implant foreign bodies such electrodes in the nerve or magnets in the muscle. We can do so-called biologic reconstruction. But we had a severe complication in the first patient because we treated them at the end of the surgery with shockwaves. And I think, and also my colleagues think, that was the reason that this patient developed very heavy neuromas. You can see here one of these neuromas in all 3 coaptation sites. We managed that with the RPNI. You see the neuroma after the resection and the recoaptation. We wrapped the muscle, the denervated muscle, the free denervated muscle around the coaptation site, and I have never seen again neuroma formation since I do that, and I do this procedure also in normal nerve reconstructions. So that's a good trick for everybody. We published that our first cases recently, and it's an open access, so you can read all about what I have said since now. Some cases you know that is a trauma case. They called me from the hospital. I was on the freeway and I wasn't able to come there early enough. So I said to my colleagues, please amputate the hand very distal, preserve or park the nerve subcutaneously, also the ulnar and the median nerve, and put on a WAC. 5 days after I was able to come to the hospital, I see then these nice results, a very clean wound, and then I dissected these nerves, and you see at the end of the operation, the stump was pretty long. It was very positive for the patient. And you see here 1 month after the TSR or after the surgery, and then 5 months the phantom limb map. She's a nurse, and now she can work again in her work, and she's happy. These 2 guys, the secondary cases, the left guy, Walter, had very, very, very heavy, also the lady of the right side, they had both very heavy phantom limb pain. And after the TSR, you can see what they are able to do. Walter was not able to put some devices in the near of the stump, and now he can do all, and also the lady, she can almost do her work where she was before. And now the special case. The first the indication, or the first patient with the brachial plexus lesion on the right side after a motorbike accident 2009 with the attempt reconstruction. That is very important, of the C5 and the C6 roots with the sural nerve interposition. So there was a recovery of the biceps muscle for M4, the triceps muscle M2, and that was the inclusion criteria. That means he was able to flex and also extend a little bit, not so powerful like the flexion. And he had also a recovery of the end branch of the musculocutaneous nerve. This is the cutaneous antebrachial lateralis. So he has also here the sensitivity, and we detected also a little decreased sensitivity in the medial part. So this was after psychological tests and so on. He called me and said to me, Dr. Gardetto, please amputate my hand. I would like to win the Olympic Games in 2026 in Italy. He's a Paralympic sportsman. He's in the Italian team of the Paralympics. A crazy guy, but he was the first and he was the right guy for that. You see that 3 weeks after the surgery, improvement of the triceps muscle strength from M2 to M3, and this was the first reaction when he saw. There's not a video, but he saw the first reaction, the VR opening and closing his hand. And here you see Ricardo, that's his name. 2 months after the surgery, where he was able to gain his first experience with the prosthesis. He was there in the lab of the company. He put the prosthesis in, and this was his first attempt or his first try to grip something. And after 15 years, he was able to open and to close the hand. And now here, Riccardo demonstrates how a real Italian espresso is made. You see this very nice prosthesis. This is the Adams hand, Italian product, and I can't show you now the whole video, but you see that he's able to put a lot of in his days. And I said he's a sportsman. He's a Paralympic sports and in the Italian team, and he won last year the first World Cup in Canada, and this year he won, I think, 3 or 4 World Cup races. And next year there are the Olympic Games. The second case, you see, it's the same partial brachial plexus lesion with the reconstruction of C5, C6. Then here you see the dissection of the ulnar and the median nerve and the recipient nerves. And 6 months after this phantom limb map, you have to know that this is a partial plexus palsy. Therefore, there are not perfect phantom limb maps, but there are maps where they can perceive all the fingers. And you know the end of the treatment. And the last case, this is a very nice case, burst trauma in 1969. I go a little bit faster, the phantom limb map. And 4 months after the surgery, she was able to move, to flex and to extend the arm. And this was her first fitting of the prosthesis. And there's a video, and you see the first time after 55 years, she was able to open and close her hand. So, yes, this is the patient. And seeing these results, the central question we are exploring is whether our current understanding of the peripheral nervous system is truly comprehensive. And therefore, we are planning now, I hope at the end of the year, we can start with a multi-center international study in which the NYU, and I'm very honored for that, is also involved. Thank you very much. I hope I'm in time, yes.
Thank you very much, Alex. So any questions for Dr. Gardetto, please feel free to type them in, and then we'll discuss them at the end. And the next speaker is Dr. Silvestre Micera. He is a bioengineer at Pisa University in Italy, as well as Lausanne. there where he holds various positions of high esteem. So he's done a tremendous amount of work. So without further ado, Dr. Machera.
Thanks a lot. Thanks, everybody. It's really a great pleasure being here with you. I will try to give you a very, I hope I can go on. Okay, maybe now. Okay, no. Okay, so what we try to work on in my two labs is to translate different kind of clinical ideas, of basic science ideas into clinical application. And in particular, we like to play with Lego bricks. So the idea is that we try to recycle as much as possible technology. And I will give you a couple of examples of this recycling, which I believe can speed up the transfer into clinics of what we are doing. As many people in my generation, we started looking at these movies and we decided that we wanted to be the guys restoring the Luke Skywalker hand. So that movie really had a huge impact. And in particular, as Jacques said at the very beginning, one of the missing things is to restore sensory feedback. This is a wonderful cover of a paper, of an article that Nature published more than 10 years ago. I think maybe Dustin was one of the people interviewed by the journalist also at that time. So the idea of restoring sensory feedback is of course fascinating, and in particular, what we try to do is to restore all the different sensory modalities in different ways, different Lego bricks to be put together to achieve all the rich palette of sensation. And what we do, not only as Dustin is going to show later other approaches, but is to go on the peripheral nerve. When I started working, there was a lot of discussion. We can discuss later if you want, but I personally believe that for amputees, that's definitely the way to go, implanted. It could be non-invasive, wearable. Also, Alex mentioned it, you're going to see something, but clearly invasive cortically, maybe it's too early and too much for amputees, but we can discuss later. In particular, there are different options. You can implant electrodes around the nerve, epineural electrodes. I'm sure that Dustin will show you also something on that. What we started working with Thomas Stiglitz many years ago and other colleagues is the idea to have electrodes implanted in the nerve, so intraneural electrodes. They're definitely more fragile and more invasive than cuff electrodes, but in principle, in the long term, what we believe could provide a richer sensation. But that's something also we can discuss later. So we developed this time electrode, and 11 years ago, actually, with Paolo Rossini, we implanted our first patient, Dennis, a Danish patient with a unilateral transradial amputation. And the idea was indeed to implant this time electrode, two in the median and two in the ulnar nerve, for 1 month. 1 month because at that time there was a lot of concern about entering the nerve, and we wanted to play smoothly. The first step is, of course, to show that you are able to restore sensation. And the beauty is that you can stimulate and you can ask the patient what the patient is feeling, and you can see the amount of sensation he was able to feel by changing the contact in the electrode. So it seems to work, but then, of course, the interest was to see whether we were able to achieve a real functional advantage. So what we did was to ask Dennis to perform different kinds of tasks while controlling with muscular activity a dexterous with 3 degrees of freedom hand with a very limited but reasonably effective sensorization. What Dennis was able to do was to show us that he was able to modulate up and down the force to generate different level of force. What I like to show every time is that there is here a red arrow. I hope you can see it. And Dennis was able to understand in real time whether there was a mistake and readjust the force accordingly. And also we compared his ability to perform the modulation task with the natural hand, the right one, or with the amputation, with the hand prosthesis, only with vision and only or only with our tactile sensation. And you can see there below that we are reasonably close to the natural sensation, but one of the limits, and I'll be back to this at the very end, is also in terms of the sensorization of the prosthesis. So there's also a very important topic for the next steps and questions eventually. It works, and then it was really patient in the Latin meaning of the word, because we performed in the last week more than 700 trials, and he was able to provide evidence. He was able to understand whether an object was more or less soft, or whether the object was more or less different shape of the object. But the interesting thing was that he was not doing that. You can see here below, relying on the offset, the final force. But he was able to use the different dynamics at the different fingers as you would do in normal conditions. So the sensation can be exploited in real time, very likely in a kind of natural way. Then what we realized is that you can really play with the patients. In particular, the interesting thing was we combined our stimulation with virtual reality. In particular, with Olaf Blanke, a colleague of mine at the PFL, he developed a virtual reality environment where the patient could see a synchronous or asynchronous lightening of the place of the finger which were stimulated. And it was very interesting to see that there was embodiment, agency, all these kind of things, but in particular, there was the telescopic regrowing of the forearm cognitively, of the phantom forearm of the patient, which is interesting because it shows that in the long term, we can really play a lot with the body representation of the patient, increasing what they can feel and how they can process the information from the prosthesis. Then we moved from 1 patient 1 month to 3 patients 6 months. So trying to go in the direction of the long-term chronic usability. And in particular, there is not much time, but just in a summary, we were able to show that the patients were able to perform the task that Dennis performed, extending the results, also kind of simulating a real world when the patient was going around with a backpack. But the very interesting thing was also that the second patient, Almerina, got the amputation 30 years before the amputation, after the amputation. And it was really interesting to see that at the very beginning, most of the sensations were not projected on the phantom hand, but only on the stump, on the residuum. Over time, at the end, most of the sensation moved as felt in the phantom hand. So clearly, this also showed that it could be patient dependent and time dependent, but more or less in most of the patients, you are able to get this phantom and tactile phantom end happening, maybe after a bit of rehabituation to the sensation. We also got very nice results, and this is quite common whenever you use sensory feedback, whatever is the sensory feedback, invasive, non-invasive, intraneural, epineural, vibration, whatever, you get an improvement, a reduction, a significant reduction in phantom limb pain. I think we can discuss later about it, but clearly one of the main reasons is that you are reproviding sensation to the brain, which is happily restoring a more natural cortical activity, reducing phantom pain. Then we try to address 2 missing points. The first one is, so touch, in some way we did it, or we provide a reasonable evidence, but at the same time, position information are crucial. But restoring natural proprioception is very complicated. You can get it anecdotally from one patient to another one, but not really in a strong way. At least this is our experience. So we did a small trick. We had the patient relearning using another channel which was providing paresthesia on the wrist, so not usable. We have them train to understand that this paresthesia was opening and closing of the hand. And then we made a lot of tests, the patient were able to clearly understand the size of objects, but also to incorporate this sensation with the tactile sensation. You see here below, they were able to understand small, large, soft, and hard objects. Also, in case of increased cognitive load. So we asked them to do a dual task. And here you can see with my cursor that the performance are, of course, worse, but not significantly worse, not below chance. So the message here is maybe we can use, if you have a chronic patient, a chronic use also training and learning. So we need to rely not only on the direct effect of the stimulation, but we can have them learning something more over time. The third step, together with the great friend and the late Sleeman Bensmeier, what we tried to do was to make our stimulation a bit more sophisticated. So instead of doing only amplitude modulation, so the higher the sensation the sensor were recording, the higher was the stimulation amplitude, we used the biomimetic model that Sleeman was providing to provide the information about from the mechanical stimulation to the firing rate of the different kind of mechanoreceptors. And then with Alberto and Giacomo Valle, what we did was to test three different approaches, actually four, but two kind of equivalent. Only amplitude modulation, only biomimetic frequency, the Sleeman approach, or the combination of them. And what it is interesting is that only the combination is able to achieve more natural sensation, more embodiment, more functional activity. So the biomimetic alone could be not enough, probably because of the limited selectivity of what we have in terms of neural interfaces. The combination seems to be a reasonable approach to increase the efficacy of what we are doing. Then, as I told you, we like to reuse the Lego bricks. And so with Giacomo and Francesco and Stanisha Raspopovic, we moved from upper extremity, just two slides, a bit off topic, but just to tell you that the same technology can be used also for transfemoral amputation. So instead of medial and ulnar nerve, you implant, for example, in the sciatic nerve, and you get the information from the sensorized sole. And the beauty of this was that there was a huge clinical advantage in the patients. The patients were less prone to falling, walking faster, less metabolic consumption, more embodiment, and so on. So there was really a clinical advantage, including, again, the reduction of phantom limb pain. That, of course, unfortunately, reappear after the stop, after few hours, depending after the stop of the stimulation, after a few days. So the technology can be reused for also for legs. But then the question I was always getting at the end of the presentation was, what's about temperature? As you know, temperature nerves are hugely small, which means that it's very difficult to stimulate electrically, even with an intraneural electrode. Maybe in the future with optogenetics or something like that, but right now with electrical stimulation is complicated. What we found, and we published 2 years ago with Soleiman Shokur and Francesco Iberite, that in most of the patients, and now we are working with Alex also with the TSR patients, in most of the patients you can get a phantom thermal map. So by stimulating thermally the residuum, many of them can project on the phantom and also thermal, cold and warm spots. They're able to use them in real time and quite well. And the beauty of this is that because it's a very simple and wearable system, it's easy to be integrated into commercial prosthesis. This is what we are working with a company right now, but we did the first test with one patient taking his own prosthesis, a Michelangelo prosthesis, and slightly modified it. And Fabrizio was the patient was able to exploit it and use it in a very nice way, including the surprise that we got of the body sensation. So by chance, he touched the arm of John the PhD student who is working with us, and he said, "Wow, this is warm. This feels human." So this shows is a simple example, nothing really scientific, if you want, but it shows that the real goal could be in the long term to restore all the palettes of sensation, including thermal sensation, which is maybe not the most functional, usable sensation, but definitely affectively very important. So this is what we are doing right now. We are now submitting the application for our next step, which will be a fully implanted and wearable system providing all the possible sensation, touch, position, and thermal in patients by combining implanted and wearable solutions, also with the new artificial skin that we integrated into the IIT hand prosthesis. So this is the next goal, hopefully for next year or a couple of years from now. And with this, I thank you for your attention and Q&A later. Thanks a lot.
Silvestro, thank you so much. That's fantastic. It just is a reminder of how incredibly complex sensibility is and how fortunate we are that we have it, and how when we lose it, how hard it is to gain it back. So that's fantastic work. Thank you very much. Our next speaker and final speaker is Dr. Dustin Tyler from Case Western Reserve University, also a biomedical engineer, who has also done just groundbreaking work in the area of sensibility. So we're very excited to have him speak and end the formal part of this webinar. All right, Dr. Tyler.
Jacques and Omri, thank you so much. It's actually quite an honor to be with this group. As you guys can tell already, Silvestro and I have been doing kind of very parallel work for a long time, and most of the time I present without him around, and so I have to do a lot of work, but he's done a fantastic job of giving some background to what's happening, and so always fantastic stuff. I'm honored to be with this crew, and thanks for inviting me here. I do want to give credit to the people I work with. In addition to the technical pieces I do, I have 3 fantastic surgeons that we work with that are critical to making this stuff move forward. So Doctors Malone, Chappell, and Anderson are also a critical part of what we do here, in addition to the whole team. Just real quick, disclosure-wise, there's a couple companies that I'm, either a co-founder, have equity in, but none of them are related to this work. And everything I'm going to present for those in the U.S. know, this is important to say, none that's on the market. This is all under FDA IDA investigation. So great thing is, following Silvestro, I knew I didn't have to do much to give you all the background stuff. We've had patients implanted for up to about 12 years now. Continuous with this, we've been doing a lot of the same kind of studies. There's a whole bunch of literature here I won't go into, but I think Silvestro well pointed out the value of adding peripheral sensation. The video down at the bottom is kind of showing just something simple as grabbing cherries, where the individual, in this case, is blindfolded, but even with sight, without sensation, really can't do something as simple as grabbing a cherry without crushing it. And so we've learned a whole bunch about the fundamentals of touch. There is proprioception that feels like muscle tensing will get, but as Silvestro said, muscle proprioception is difficult. So we've often done the same thing with sensory substitution. We have had 6-week home use that we've reported on, but I'm going to talk about the actually moving to clinical trial side with a crossover study here at the end of this. Another thing I wanted to point out is that perceptual learning is real. And so Silvestro laid it out, but it's amazing how the visual tactile synchrony is important. So whereas a user would have a prosthesis in the morning, they may have sensation at the base of the finger based on where the nerve electrode is. By the end of the day, when they see the pressure always at the fingertip, that sensation will move up. And we found that over time, that's actually a permanent movement as well. And so a lot of this stuff I'm presenting on the upper extremity today, but in the same way, just know that we've got now active programs with probably 6 to 7 lower extremity subjects doing the same kind of thing. So I'm going to focus on the upper today. So sensory is a point, but I also want to make sure that we recognize that, as pointed out, high degree of freedom control is actually really critical. And what we've been learning is that the sensory component is more of an emotional connective element. It's important for people to recognize they have a hand back to connect with individuals as much as it is for function. But the degree of freedoms are actually really critical. Wrist motion, wrist extension, and flexion is almost as important as anything else that we're adding to this. So 4 degree of freedom systems is really important. And we've also then shown sort of this idea that multisensory integration has its place as well. So individuals can do things like reach in a bag without looking, feel what they're reaching for and grab it and pull it out. So all this stuff we've reported on, the kind of the bits and pieces. But as been mentioning, we want to be able to move on to how do we get this towards a clinical product, right? So a lot of us have been spent years studying the idea of what does sensory add, and it seems obvious now, 12 years later. But when we started, there was really unclear if we could even provide a sense of touch. But I think we've got that pretty well under, in study, as a lot of literature from many labs have shown. The question is, how do we take it home? So this is our original sort of system. We, as Sylvester pointed out, put electrodes around the nerve. We'll show a picture in a minute. And we add electrodes inside the muscle for when the residuals remain, or from a TMR system that may have targeted muscle or RPNIs, we can add electrodes within those. But we had a percutaneous lead system. And so subjects, this has been actually very reliable for up to 12 years. We've had people with this percutaneous lead, but it's not really the best system for going home. And it limits us to like a maximum of 48 leads. The number of contacts we can put on the nerve are like 16 channels, individual points that we can stimulate with, and a limited number of intramuscular electrodes. So what we developed is this, what we call the iSense system. But really what's important is now it's a fully implanted system, so we can communicate to the external hub through Bluetooth. It connects to a cell phone for control, and then it connects to the hand. So basically, it's a bidirectional system, sensors in the hand, as you saw earlier, back through that system, communicate through Bluetooth, stimulates a nerve, the user does a function, records from EMG, sent back out, controlled to move the hand. So a completely closed loop system where our round time is about 13 milliseconds to move from an intent for the user to the hand to actually be moving. And so this is all work supported by DARPA, and they're revolutionizing prosthetics and the derivatives from there. Now we can do up to 64 stimulation channels. We can do 16 bipolar EMGs, or single-ended if you wanted to do those approaches. And we actually, the design is we have connectors built into this system. So while I'm presenting work we've done here with the extraneural approaches, basically by having a compatibility in the in-lead system, we can add any electrode to this. So it's, we use this electrode, we have good success with it, but it's not limited to that. So the idea is, again, in the reuse idea that Silvestro talked about, we want to be able to be open to a different technology. And so the KISS system, this is the only real geeky slide, technical side here, but I just want to show that we can basically record features out of this system. So 16 muscles in real time, sending us information for as the user thinks about different tasks. We can record different patterns. We put that through machine learning algorithms to cause the hand to move. If we need to do testing, we can collect raw mode EMG as well for this. And we have a very complex stimulation system where we can, change the amplitude, change pulse widths, multiple channels at different frequencies, modulate that stimulation for, as Sylvester pointed out, what you modulate the signal as is important to the quality of what people feel. And that's an actually very active area of study, as was indicated. And so we now have we're about 2 years into, I'm going to report results of somebody that's been in the trial for about 3 years now, 15 subject randomized pilot small cell randomized clinical trial. And the question is not, can we feel the hand, but really, is it better than the standard of care, right? What's the state of the art prostheses? Because all this stuff is cool in isolation, but the real question is, does it make a difference at home? Does it really change a subject's life in everyday wear outside the lab? And so I'm going to give you some results from that. This is my point here. A lot of this is Sedona Katie. She just graduated her PhD, so I want to give her credit. And then we have a really strong clinical team that works on this. As everybody knows, you got to have a lot of people to make this happen. The basic design, essentially we have a baseline. We take this standard state-of-the-art prosthesis, which happens to be a bionic hand, measure some baseline data. Then we have 100 days where we're in this is the Luke arm as part of the DARPA project. So we have the iSense Luke. And then we have the state-of-the-art again for an equivalent 100 days where we do all the same measurements, but back into their state-of-the-art system. You'll see through the presentation, there's like 3 phases within phase 1. That's just as we were tuning with this first subject, tuning sort of the control parameters that made some differences, as you'll see, but in general, fairly stable. Again, interest from the patient, what are we looking at when we evaluate the subjects? TMR is fine, so we can work with subject with or without TMR. We look at functional assessment of the residual limb. What is their normal prosthetic use? Do they have phantom pain, which, as indicated early, sensory does actually eliminate that. We account for rigidness of the socket, where that is relative to the implants, make sure we align the implants to try and minimize impact. Look at the residual limb, the soft tissue envelope, and whether we have issues potentially of skin erosion, any painful neuromas, joint contractures, etc. And then we also do some ultrasound information to really align that system to the subject. We've had 2 people implanted. I'm going to give you both the good and the ugly. So it's, this is moving towards clinical trial. Everything's important. This is an individual that was RCT01 was actually in the study, first implanted in 2012. 2013 actually, and then he upgraded the system. And so he's been in with us for a very long time. And then our CTO2 is de novo. We had the accident in 2018. We did the implant in 2023. This is just a quick view of the implant. This is sort of the multiple steps. Ultimately, we place electrodes around the peripheral nerves, so the different nerves. We actually start by placing EMG electrodes in the distal musculature. So it's kind of an idea here. We route all these leads subcutaneously just underneath the skin to exit sites where we implant the external modules. So we have these sort of satellite systems which do sensing and stimulation. And then those are routed to a central pacemaker where we have, or a pacemaker-based system where it's the power and the communication through Bluetooth. I love this picture on top because this is this is actually Sedona holding a Bluetooth while surgeons are working, connecting to that device to make sure it works. So again, a wireless connection that we can use. So this subject was implanted in 2021. Again, we were learning some lead things. We had to do a modification surgery in 2023. And this is the subject all the data after this will report on. The de novo implant was in January 2023. But unfortunately, what happened with this subject is there was an infection set in on the system. That subject was actually explanted in 2023, about 4 months after we started. Not great, but the thing is the subject fully recovered, wanted to re-enter. So even though we're doing a lot of material in there and there are risks, actually we think that it's not something we can't manage. So in general, none of the electrodes have ever seen an adverse impact over. We have roughly 7 upper extremity subjects up to 12 years implant continuous. We got lower extremity. There is no impact on the nerve with any of these electrodes over time. We have seen no impact on the muscles either. And these systems can be removed, modified, updated as needed. So even though there's a lot of tech, it still can be managed depending what's going on. So a couple questions that we want to ask ultimately here is what's the value of increasing the channel counts? So as I've said, we've gone from basically 16 channels to 64. Does that matter? Is it worth all the extra complexity? Number of TIMs, these are our intramuscular electrodes. Is it worth adding more electrodes? And so this was the early subject when they were first implanted in 2012, one of the first sort of reports on this, 8 channels. We get nice distribution across the hand and isolated sensitivity, even though we're outside the nerve. So we're excited about that. We add more channels. Now we put 2 cuffs on the same nerve at different places, distal and proximal. And in fact, we can increase the sensation locations that we get all over the hand. Some of these are proprioceptive. They feel the hand's tensing. So that's why they draw the whole hand. Others are very isolated to different finger areas. And so what we found is that if we look at just tactile information, we go from the 16 channel, you get about 17% coverage, all the way to 80% coverage of the hand. Plus there's a forearm, which we're not reporting here, but sensation of the hand. If you look at all percepts, including the proprioceptive or the tensing feel that people report, we go from about 29% with the smaller system to almost the entire hand. And so we think that the adding channels actually is advantageous. And if we look at, they are unique sensations. So we make a measure of how similar the different sensations are, whether they overlap each other or distinct. And depending on how strict you make that criteria, every channel is unique when you don't have any criteria at all, to the point where everything has to be exactly different. They get small groups. But even at like 70% cutoff, we almost have doubled the channels and 20 unique clusters of sensation from those 64 channels that are very distinct through that sensation. So in all cases, the added channels actually add the sensation, unique and valuable sensations. We've looked at control as well, and I'm not going to spend a lot of time on this because it's really focusing on sensory here, but we've gone from 8 channels of EMG, 8 different muscles. We add 2 muscles, and then we add redundancy to muscles as sort of the progress. All of this stuff is using neural networks, machine learning to get 4 degrees of freedom on the output. And ultimately, we can increase the match performance, how well the hand matches a given profile by about 12%. We can reduce time to target by several seconds, so how quick they can move the hand and the efficiency of the direction they move the hand. So they're not wandering around in space. They're actually going directly to a specific target task within by an 8% reduction. So, or improvement, sorry. So, improving muscles, maybe not as dramatic, but essentially it is improving that system. So the more, the better. So does it really matter? The question, this is all great engineer talk, but do we really care? And so what we've sent, now that we've sent the people home for hundreds of days working with the system, again, we start with baseline, the gray here, and everything, we have a lot of validated measures for social interaction, well-being. Do they feel better interacting? Are they satisfied with their system? Is their perceived ability to use the prosthesis and the embodiment, do they change when at home? So again, outside of the lab, using every day, they have a choice to use the hand or not. They can put it on, they can take it off. It doesn't really matter. We don't control that. We just measure it. And all of these measures improved. And again, as we improve the control here in the different phases, we can see that that also caused in value. So more channels, better control, and sensation at home where it really matters is making a valuable impact in what we're doing. And all these scores with the pluses are meeting the validated minimal detectable change from prior literature that set these standards. So that they're doing what they need to do. In the lab, how does it, the phantom experience, Sylvester mentioned this out, we actually look at the residual limb and relative to their perception. When you have the full good control, full sensation, they're almost equivalent. And so they do this every day, and these are actually directly linked. And interestingly, even after 100 days, and they've had this experience, it's not learned. They actually, with their standard or the SOA without sensation, without the control, goes back to sort of the pre-values. So it is related to the system. And the phantom hand, a lot of times they're in sort of a contracture position, and we look at that and they start to describe the hand opening as kind of like what kind of ball they can hold, is how tight it is, and they get up to almost a soccer ball or almost fully open when they have sensation versus without. So all useful things. We're going to finish on a couple of videos that show the value. So this is the state of art phase. This is a 9-hole peg test. I'm not going to let it run to the end because it's actually painful to watch. These are very difficult challenges. No sensation, poor control. I can tell you he does this for a while like that. So I'll stop that video. This is now with sensation, with a higher degree of freedom control in the prosthesis. He has the ability to not just reach in there, but you can see him now extending the wrist, repositioning the hand, picking up that object, and essentially doing what you and I can't, which choosing a value of a way to get that peg in there, but has complete control over that. And so there's a significant improvement in something like dexterity measures. This is just asking him to write something using the standard prosthesis, trying to hold the hand and move through. I'll watch for just a second, but you'll see the issue of kind of holding the pen. He doesn't have a lot of control over the hand. And we asked him to write the word letter, right? So write a letter. You can see kind of the result. These are of equal size, so we kind of size match them to give you an idea. Takes a while. He's struggling with this. And then using the prosthesis with sensation, better control, you basically get a different grip, easy to move the grip pattern, hold the pen, and ultimately able to write in a much sort of more refined, smaller, more controlled. I'm not going to say natural because that's obviously biased, but a much better process than he was before. And finally, the last thing, which I think is a really powerful idea, most of you know, work with this, is compensatory movement. So doing something like a door handle with limited function and ability, I want you to pay attention more to his body than the door, right? So in trying to turn this thing, he has to first get a grip, and then he's going through all kinds of contortions to get that handle to change as needed. And again, I'm not going to spend a lot of time watching that because it's painful, but you can see how difficult it is, where when we give him the higher degree of freedom, get the full control, he reaches the thing and basically just manipulates the wrist. So he gets a good grip and turns that handle. And so much more natural, or at least lower effort, less compensatory motions. And we did the full Amula from Linda Resnick and her group, and ultimately show that there are significant changes in the everyday activities, right? So the activities of daily living. So that's a real quick run through. I think I love this at the end. I'll let the subject say a few things here. So at the end, I'll say for him, he's going to talk in a second, but he basically wanted to do peel potatoes again. So we always ask, what do you want to do? And he wanted to peel.
Yeah, and I ain't necessarily trying it, but it's happening, so I'm letting it.
So the idea is he's got the motion of the hand. He has a higher degree of control. But what I really like him saying is he's not really thinking about how to control the hand. He's not doing anything unnatural. He's just thinking about moving. And so he's kind of out in the environment doing standard things, not by thinking about I have to move a certain way for my prosthesis, but doing it. And so I love the quotes that he has. Sensation was great. I would pet my dog and could feel what I was touching him and how hard I was touching him. So again, really everyday life stuff. Prosthesis sensation was working this week. I felt like I had my hand back, which made me want to wear it more and longer. Sensation felt like my hand worked great this week. I felt more confident in my ability. And then when we went back to the other hand, the control was okay. Most of the time, still dropping things at times, missing, not having sensation, and more freedom of movement of the hand. So clearly making an impact on everyday life when he's at home. These are things he would fill out in a survey at the end of the day, unprompted by us. So that's a very quick through what we've been doing. I want to thank a ton of people, obviously the subjects themselves, but there's a whole bunch of folks that have worked on these projects. And as Jacques and Omri have talked about, I'm hoping to add them to the list as we go through as well. But after the acknowledgments, I want to make sure he's there. I do want to end on one video, which is, you may have seen this or not, but I love this video because we talk about sensation, its function, and all the engineering terms of what we can do, but we forget what really matters. And I think this video captured it. This is our subject. First time he ever felt his wife's hand. I know it's a little sappy, but it really does have an impact for me. It's just the ability to re-feel somebody that means something to you has an impact. And what I like is when he's here, you're playing with my fingers. You're playing with my fingers, he said. And then he actually just reached out to stroke the arm, again, to have that human connection. So thanks for your time and listening. It's a quick whirlwind through, but I think what we've been finding now that we have home use is not just can we do all this stuff as we've shown over the years, but we in fact make a difference in people's lives. And it's compared to the state-of-the-art, best available prosthesis, we do improve things, and it returns people's hands. So we're excited about how to continue getting this out of the lab and getting this into clinical availability for everyone. So with that, I'll stop here and thank you all for your time. I look forward to questions.
Absolutely. I want to thank all of our speakers for donating their time and their expertise and really highlighting the importance of sensory function, not only as it relates to motor function, but also as it relates to just human interaction. And I think most of the questions and hopefully the discussion that we talk about will be a springboard into how we can, like you said, Dustin, bring this amazing work that you and other people are doing into the hands literally of these patients that we're trying to treat. And I think that it's incumbent on centers like ours and others around the world to try to bring this into daily patient use. And so keeping that in mind, we're going to start with some questions from the audience. And then I just have a short list of 300 questions that came up while I was listening to your talk. So first of all, from the audience, Alex, if we can go to you first. There was a question about indications for the TSR surgery as opposed to more traditional neuroma management such as RPNI or bearing the nerves or even TMR. So maybe you could talk a little bit about how you decide to indicate a patient for the TSR procedure.
Yes, I think that we know a lot of TMR since 2002, and for me it's important to bring in the sensitivity, and therefore we have now operated about 15 people around the world with this technique, and we saw that all these people with the upper limb, with the lower limb, we have operated about over 80 people. We saw that all these people, after the TSR operations, the phantom limb pain disappeared and or not occur at all in the primary cases. And therefore, my suggestion or my thoughts are: you have to give the nerve something to do, and then there is no chance that he can develop a neuroma.
And sort of springboarding on that question, when we a lot of times with amputation reconstruction, we're trying to avoid a phantom limb or phantom limb pain. But in your procedure, you're actually your goal is actually to reproduce or map that hand onto the residual limb. So I guess my question is do patients that you've operated on complain of that in a negative way, or is that's actually the goal of the procedure?
Yes, that's the goal. That's the aim to innovate this forearm in these cases and to produce a phantom limb map, but not with the pain in the brain, but without this, because we are closing this lac in the motor cortex, in the sensory cortex, and I said it before, we do a biological reconstruction. We reroute these nerves. We don't let they there and do nothing. We root them. We give them something to do, and we have the necessary, like you said before, prosthesis with feedback systems.
And so on that as well, can you talk a little bit about the evolution of the vibratory sensors that you guys have been using? And I'm sure the technology of those has advanced and changed. And so how has that impacted the patient experience
Because we have this experience with the lower limb. With the upper limb, we haven't this experience because they are always all in the development. But in the lower limb, we have this experience with the vibratactile feedback systems, and we know, and we have also published that this is giving a real, genuine, and authentic feedback through these fine vibrations on the renovated areas, and therefore I think also electric stimulation and other stimulations are possible, but the vibratactile stimulation is very easy. And I hope that also in the upper limb now with the prosthesis, I know some US, I know one US prosthesis that is able to do, and I hope that there are coming a lot of on the market now.
Wonderful. And then one final question that I had was about your post-op therapy.
Yeah.
Yeah.
Yes. No, the post-op therapy is very easy. We do until now we do a lot of TENS therapy and therapy with the OTs, and but I would like to develop, and I'm in work with two companies in there that they have to produce a small device with vibrators that you can put on in the next day after the surgery, so that you can, with a elastic band with five, I think five is enough, 5 vibrators there, and then so can you just stimulate this vibration here at the residual stump without so there is until no sensation, but the vibration now is or the brain can now learn about this vibration, and when the renovation is reaching this skin, so the brain has just some reaction about that.
Yeah, that's wonderful. And
I hope that maybe in half a year we have this device on the market.
Amazing. I think there's so much room that we need to improve on post-operative recovery and peripheral nerve surgery. Shifting gears a little bit, we had a question from the audience about sort of the mechanics of the implantable stimulators and sensors initially, and I have many more questions after, but the question was around the mechanics of how these devices are charged. Are they implanted and wearable? Does the patient turn them on and off? So Dr. Michera and Dr. Tyler, are you able to speak to that, first of all?
Certainly.
Dustin, go ahead.
Go ahead.
Yeah, sorry. Yeah, so we the charging is, so the device, the battery is in the part in the chest, and it's basically the same as any other implant for, say, Parkinson's disease or otherwise, right? So you can charge this thing inductively. So there's basically a coil wear over the top. We've tested runtime. It's anywhere. We've never had to charge it during the day, so there's at least a full day's wear. The subject can charge it overnight, and then they've had multiple days of wear with this. So it's at least a single day use under full use, and then you recharge it, and you're good to go. The communication, as I meant to indicate, but maybe not clearly, is Bluetooth. So for timing reasons, we have our own little Bluetooth dedicated communication device, but in theory, it could be any cell phone or any sort of Bluetooth device that you're in there. Obviously, security issues and all that kind of stuff are built into this system as well. So the mechanics of the system are basically like any implant. The challenge is the amount of cuff electrodes and the wires we have to run is the difference between most of the other systems. But charging is inductive coupled, and then communication is pretty straightforward to an external device where the user can set all of the stimulation parameters and things. And the other thing I'll say, and then I'll turn it over to Silvestro, is that we try to keep the implant as stupid as possible and keep all the logic for the control systems, everything else in the external, so those can upgrade and change over time much more rapidly. So as we have new controls, new processes, they can go onto the cell phone or the external device, and the internal still just follows it and does what it's told to do.
Usually we keep the surgeon as stupid as possible. That's usually Dr. Michera, do you have any comments about that?
Just to add a point, also Dustin showed clearly during his presentation, a very important point is to find in the evolution of time a good trade-off between the number of the electrodes, which also means an increase or decrease complexity of the implantable stimulator and the real possibility you can provide to the patient. I was mentioning during my presentation the issue of the sensors. I mean, clearly you can have many sensations, but then if you're not able to sensorize the hand in a complicated way, then maybe you don't need them immediately, all the sensations. So it's is really a loop. So when both myself, Dustin, Max Ortiz, everybody started, we had few sensors because we were able to deliver something, no?
Right.
So now we know that, as we showed, both myself and Dustin, you can restore a lot of sensation. So you can increase the number of the sensors, but then also this means increasing the complexity of the overall system. So you have to find a way from time to time to deliver something to the patient, which is in some way closer to the clinics, not waiting for Luke Skywalker. In that sense, for example, as I said, we are now working with Alex, for example, the possibility of using wearable solutions, not only vibration, but also for thermal, also at the solution that we are going to start working with him, could be a good step toward the Luke Skywalker complexity. So to find something that it is usable for the patient now, delivering technology that can go to clinics while working to the next step.
Yeah, I'm going to add to that real quick. Not only that, but as you add new sensors, you have new places to break. While we showed the Luke arm, it's beautiful, or it's called the Luke arm, right? That's what Deca called it. Ultimately, it's wonderful, except it breaks more often because it's hard to maintain all the motors. It's heavy. There's a lot of clinical challenges. And I think the other thing that we always find is, and I've been in medical devices for a long time, the balance between what the user has to do on a daily basis versus what they're willing to do is actually surprisingly different than you would expect, right? Subjects are really excited about things for a day or two or a week or two, but if you ask them to do a lot of extraneous, it becomes challenging. So building the systems into the socket where you just put it on and it's natural. All these things really come down to, you think you're going to give them their hand back, but the reality is they're like, screw that. I'm going to go back to my body powered or my other because I don't want to deal with all the hassle. So it's really a much more complex problem, as Silvestro was mentioning, than simply creating the ability to do it. There's so many other things like surgery. Who's going to be able to do that? How many people can put it in? How complex is the surgery? Who's going to pay for it? All that kind of stuff is actually more of a problem than what we're doing technologically now, unfortunately.
Yeah, absolutely. The logistics of it. And what's interesting and great is this is bringing the world of, peripheral nerve stimulation, which has been in the pain management and spine surgery and peripheral nerve spheres for a while, but it's bringing this into actually functional restoration. And so I have a couple questions about sort of the mechanics from a surgical perspective. Like, for example, you guys mentioned the differences between placing the sensors peripherally around the nerve and also intraneurally or between fascicles. Can you talk about your experience with that and if you think there's benefits to either of those?
That was a 15 years discussion between myself and Dustin.
That's right.
Just summarize it in 2 seconds.
Give us some beer, Omri, then we can have that discussion.
It will be a long discussion. Honestly, there are pros and cons. The idea is the beauty of what Dustin has been doing for many years is that a solution that provides good enough sensation, but is really more stable and easy to use. What we try to do is, if you want, what could be maybe the next generation. So to find a way to have something a bit more complicated, even if honestly I must say that the surgery is pretty simple. It's just a needle going through the nerve. It's something that you guys can do easily. And over time with Thomas Stiglitz, we improved the stability and robustness of the electrode. So let's say our challenge with respect to what Dustin just presented is to show that maybe in the medium term, by increasing the complexity of the sensation in the hand, we will provide more rich sensation that eventually could be exploited. But in terms, the important point is that the technology, the intraneural technology, it's not, when I started working on this, people were saying, the guy is kind of Mengele, entering the nerve and destroying the nerve. I mean, it's really not the case. It is important to show that the increased invasiveness can provide, at least in the medium long term, a real advantage with respect to what Dustin is doing. That's our challenge. But the damage is really limited, and the patient get back to normal kind of activity with no particular issue after the intraneural implantation.
And another question from, sort of the basic mind of a surgeon here is, when you guys were talking about the fact that you're able to do these implantable devices in patients who have had TMR or other traditional approaches, just from conceptually, a patient with a transradial amputation has a median and ulnar nerve that are not connected. Let's say they're not connected. So are you still having patients having traditional neuroma and phantom pain even after having these implantable devices, or are you doing them in conjunction? Do you recommend doing them in conjunction with traditional neuroma and amputation reconstructive procedures?
Yeah, I mean, from that, I don't think the other procedures really impact these electrodes, right? So there's two kind of questions in your question, right? One is neuroma versus centrogenic pain, right? There's a difference between a neuroma, which is actually firing activity, and something that's the dysregulation of sensory because you've lost it, right? And so I would fully advocate, if you have a neuroma and you have a procedure doing RPNI or burying it, do it. It's not going to affect what we do, really. And the same thing from a TMR. All these nerves still have muscle in them, and so we can get sensory independent of muscle. And as we know, there's like 100 or 1,000 to 1 ratio of sensory to motor. So it doesn't really impact us to be able to get the sensory. What I didn't show here, the other important thing about this is that, even though there's still innervating muscle, one concern was, if we stimulate the nerve, do you cause muscle activation, which actually messes up control? And we've seen that it doesn't, right? I mean, so at the end of the day, we can get enough separation of motor and sensory in a common nerve that you don't really have to worry about this. You don't have to separate the sensory and the motor fibers. You don't have to do all these different things. And ultimately, if they're using a TMR for control, particularly if you're up transhumeral, right? I mean, if you're up above this, you need to do these things to get the hand. I don't think that has any counterindication for what we're doing. At least I'm pretty sure it's the same for Silvestro, but definitely not for us. I mean, we've removed all that as a counterindication. Early on we had it, but we don't think that's an issue, so that's all been removed.
If I may, I totally agree with Dustin. I would even say that there are kind of often two parallel approaches: the ones like me or Dustin making implants in the nerve, and the surgical approach, the wonderful one, for example, that Alex presented before. Mm-hmm. What I really think is that in the medium term, we should start working together, combining, when necessary, different approaches. Because, I mean, this is really potentially a very nice synergy to implement.
Yeah, and I'll just emphasize that, right? Sylvester was saying earlier, you asked us the question of which electrode, which is always sort of like, okay. But at the end of the day, I think all of them work, right? Each one has a place. And so maybe you need an extraneural works perfect in one place. Maybe you want to do an intraneural in another. The point is, how do we build the systems that are, not so constrained to one or the other? I think we combine all of them. We combine Alex's stuff. We combine Silvestro's stuff. At the end of the day, it's not about what paper I publish. It's about what we do to the subjects, what we can bring for patients. And if we can combine all these things, we're all going to be better off. And at the end, so is the patient, which is all I really care about, to be honest.
So keeping that in mind, Dr. Gardetto, I have a question for you that came in through the audience. Was, in terms of telling patients who are going to be undergoing a TMR procedure, what do you tell them about when you expect them to be able to, draw the mapped hand, or at least to start to have that sensation? What's been your experience, and what are you telling patients preoperatively?
Yeah, we saw that the reinnervation began after about 1.5 and 2 months. And how I said before, it is very nice that we could now have a prototype of this vibrotactile system to put there, so that the brain can train this perception. And we saw different times. In one patient, I can remember that he had the first perceptions about 3 weeks after the surgery. it is not, you can't understand, or I can't understand why. And when I presented these cases with the brachial plexus lesion, I can't explain exactly why this is possible, or even after 15, or after in the lower limb we operated also people after 30 years, that there is this plastification of the brain possible to perceive this sensation after so many years. So yes, I saw this renovation times in the upper limb between 2 months and maximum 2 months and maximum 6 months.
I mean, that seems to sort of mirror what we experience with TMR type procedures. And I have to be honest, is that sort of echoing what you said, in our centers, sometimes we have patients who have significant, pain burdens and phantom limb, that we do these procedures and very quickly they start to experience improvement. And we have other patients that it takes 6 months, like you're saying, to be better. And I wish I knew why. I feel like we're doing the same surgery. And I think it's another example of highlighting a little, at least I know, about the nervous system. And so I appreciate you guys helping understand that. Now, similar to that topic, you guys mentioned the aspect of almost reverse telescoping of the sensation, which I find fascinating, and it makes sense from a cortical reorganization standpoint. But how sort of important is that, and can you explain why it's happening? Because it is sort of the TSR that Alex is talking about is almost kind of jumping over that, which is fascinating. So can you guys talk about this reverse telescoping and how that comes into play clinically?
My first thought on this is it's not just the telescoping, it's actually the entire sensory I put up the quote from Kant, right? And essentially we are aggregators of sensory experience, right? And so I think the idea of visual tactile synchrony, the idea that you see something touching a finger and you feel it simultaneous, is important for how the brain goes through plasticity, right? So there's the real question, one of the questions is the brain rewiring, or is the brain just sort of reopening circuits that weren't used anymore, right? Because at the end of the day, I think this stuff happens faster than rewiring in many cases. So I think it's a matter of which circuits are turned on and turned off or reestablished. And so I think there's that component of it. And I also, I think that we find, as Sylvester pointed out, we'll see the same thing where somebody hasn't had a hand for years and they'll start pointing here, or they've had phantom where they feel pain in the lower extremity because they had an infection, which is why they removed the foot. So there was a lot of sensation in their calf that was painful. The initial sensations were there and painful, but then they moved down to the foot and became normal. Or the ones in our upper extremity that haven't had a hand in a while, they'll start in the forearm, but then they end up 2 weeks later in the hand after they've had this for a period. So I think we have to, we haven't done the detailed studies and, some of the EEG stuff that Sylvester's done. Maybe he can answer this, but, it's a very rapid thing. And I don't think we should underestimate the power of the visual tactile synchrony, the idea of senses wiring together, firing together, and these pathways reconnecting, reopening, reestablishing themselves. Maybe not just totally rewiring, but the circuitry going, hey, now I can see my finger in this. Those are back together.
Yeah, if I may, I totally agree with Dustin. And I would say what I liked of the telescopic is really to show that we can play with the cognitive aspect of amputation in a very smart and, let's say, effective way. So that's what I think. The more we are going to have this patient implanted chronically, the more we should play with them in this specific, with neuropsychologists, with neurologists, cognitive neuroscientists. There are a lot of things we can do to understand what is happening and to play with that in a smart way. Even if you want the proprioception remapping, I mean, it was just anecdotal, but it shows that you can have the patient going through learning and training to get something more or something else. So there is a variety of things we could do when this device is more and more, like in Dustin's case, is going to be clinically, chronically usable over months or over years.
I mean,
that's what I like.
A similar sort of much more basic example in hand surgery is tendon transfers, and watching patients reorient and and change the function. And it'd be interesting to, like you said, to correlate that with functional MRI studies, to see how that would correlate, if that's something that all three of you, I think the work that you guys are all doing could be brought in to help. We had another question from the audience that's sort of similar. If you guys could, I think I have my opinions on this, but I want to hear what you guys say. Is how important is the sensory function in these grip patterns that you're seeing in transradial amputees? Meaning how not just restoring on and off sensation, but actually the discriminatory, vibratory, tactile, and how that influences grip patterns that can be used in a prosthesis.
Yeah, I don't. Sylvester's got a lot of the same ideas, so I'm not happy. I mean, you go first or whatever. But we thought sensory was going to be huge, right? It's going to make a big deal in every one of these activities of daily living and stuff. And it turns out to be important. But I think we need to understand sensory's role in grasp and activity better. And what I mean by that is it's for the things that we typically don't even test in prosthetics because there's no ability to do it. So, for example, if I grab a pen. When I grab the pen, I actually look at it and I grab it, right? I rely on vision more than anything else. But what I can do is I can look away and re-engage the conversation with you, but I don't have to watch my hand anymore, right? Because I have this feedback system that's telling me I'm gripping the pen, I'm going to lose it or not. And so things like that, prosthesis wearers, they have to focus on the pen or they don't know they're going to drop it, or especially if they have a fragile object, right? So I think we need to understand that we need better tests that will actually look at more refined grasp patterns and things that don't show up in every day. We talk about holding a ball. That's pretty easy, right? But holding a ball while having a conversation, or I'll talk to our subjects about holding their plate in a buffet line and talking to people, is a horrible thing to do. And so I think it matters a lot, but I also think it's usually at the, I don't want to say sub-perceptual, but it's usually at not a conscious level that we're thinking about it, right? We use touch to allow our consciousness to move on, to allow our senses to be unloaded to do something else, our vision, etc. So I think it's super important, but it's not the obvious way that everybody wants it to look for, right? We always have people hold an egg. That's kind of a bullshit test, pardon my French, because the egg is really easy. That shell is not that hard. And it looks cool, but it's really not that hard of a task. It's other things that are like, how do you do tasks where I don't want to look at my hand, or I'm grabbing over in an area and I want to make sure I grab these things. So I think it's really important, but differently than most people have been thinking about it up to this point.
I do agree. If I may add, the other issue is that the limited dexterity of the prosthesis is also limiting the impact of the sensory 100%. Feedback. So I mean, clearly, if you have to do only this, okay, you can deliver. I do agree that they say being able to separate vision and touch is very important. So I can grasp this and manipulation it while not looking at it. But the more the prosthesis hopefully will be dexterous, the more the sensory motor integration will play an important role.
Yeah, that's a great point, Sylvester. Go ahead, Alex. Sorry.
You know that the hand is the second brain what we have, and I think more you have the feedback authentically or genuinely, more impact is in the brain and more environment and more embodiment is there, and therefore it is very important to have the quality of the feedback and also the quality of the sensation from the limb to the the sensation from the limb to the brain, and if that is authentical, so the impact in the brain, my opinion, I'm a surgeon, is much higher.
Yeah, what I was going to add is that there's a lot of processing that happens in the brain before I feel it. Right. I think what people don't realize is how pre-perceptual processing works. Like we published recently a paper that's like you respond hundreds of milliseconds faster to touch than vision, but you don't even know. It's pre-perceptual processing. And we tried to study that. We actually wanted to show it made a difference in the prosthesis, but to Sylvestro's point, they suck. Right. So I can't show the value of that because I don't have a prosthesis that has the capability to respond in that kind of speed. So there is this tie between, and I think the idea that I'm using, to Alex's point, sensory information within the standard processing circuitry that is well before I even feel it is super important. And it also leads to something that Sylvester said earlier as to whether cortical stim is actually the right place or not, because that's way post in the process, right? I'm processing in this, everything coming up the spinal cord, the cerebellum, and everything before this as well. So there's a lot of interesting details. The stuff we have to study now is well beyond I felt my finger. And that's where it really gets interesting to your questions.
Well, I'm going to turn it over to Dr. Hochboard in a second, but I want to thank all three of you, Alex, Silvestro, and Dustin, for the work you're doing and also for confusing me even more. So thank you. And I really
pleasure.
Yes, and I really hope that we can help further the work that you guys are all doing. So I'm going to turn it over to Jacques to close us out.
Yeah, no, thank you very much, Alex and Sylvester and Dustin. This is fantastic. There's some pretty intense things that were covered here, but I think everyone that watched this, all the participants can walk away with having a deeper appreciation for, one, how critically important sensation is, and how critically important sensation is for motor function. Feeling things, moving things, grasping things. It cannot be done without sensation, and also how daunting of a task this is. But thankfully, there are people like the three of you that are working aggressively on addressing this, and all the work that you've done over the past couple decades. So thank you so much. But I think we're out of time. Appreciate all the participants. This will be available for you to view. I think that will be helpful as well for us to review it and come back with more thoughts and more questions in the future. And then look out for our next webinar, which will probably be in about 4 to 6 months from now. And the topic hasn't been determined yet. And then hopefully we'll see you all at BreCon 2026 in Charlotte, North Carolina. All right. Thank you, everyone. Have a great evening. And see you.
Thank you very much.
Thank you all.
Thanks a lot. Great pleasure.